It absolutely gives me enormous pleasure. Today, we are delighted to be joined by three leading experts in women's mental health to talk about violence, trauma, and mental health in conversation with Misha Barr. We're going to explore the issues and evidence to identify how we can design a better mental health system response and build workforce capability to meet the needs of women who have experienced violence and trauma. I'm really delighted to introduce each of them to you. First up, we have Dr. Manjula O'Connor, Adjunct Professor. Dr. Manjula O'Connor is a clinical psychiatrist and Royal Australian New Zealand College of Psychiatrists Family Violence Psychiatry Network Chair. She's Adjunct Professor at the University of New South Wales Department of Social Sciences and Senior Fellow at the Department of Psychiatry, University of Melbourne. She's a clinician, researcher, reviewer of journals and advocate, and works closely with community in prevention of family violence. Her clinical and research work is around women's mental health and family violence, and she is often invited as a keynote speaker at national and international events on this topic. She's won many grants to prevent family violence, early intervention, awareness around help seeking. Her current project is around increasing recognition of family violence and coercive control in psychiatry, use of community-based theatre to enhance early intervention and primary prevention of family violence in communities, suicide prevention and mental health literacy in migrant communities. Professor O'Connor is also a member of the South Asian Community Ministerial Advisory Committee. So welcome aboard. Maggie Toko. Maggie identifies as having a lived experience and as being Indigenous to the Otora and comes from the Ngati Whatua and Ngāpuhi tribes. Maggie is currently the Assistant Commissioner Lived Experience and Engagement at the Mental Health Complaints Commission. Maggie has worked in homelessness, youth, sexual assault and young women's services, as well as mental health, most recently having been the CEO of VIMIAC, the Victorian Mental Illness Awareness Council and the Peak Consumer Organisation in Victoria. Welcome, Maggie. We also have Professor Kelsey Hegarty. Kelsey is an academic GP from University of Melbourne and the Women's Hospital. She leads the Safer Families Centre, which is transforming the health system to address domestic and family violence. So welcome along, Kelsey. And finally, but not least at all, we have Misha Barr. Misha is the Manager of Policy and Health Promotion at Women's Health Victoria. She oversees work in policy, advocacy and research across Women's Health Victoria's priority areas, including sexual and reproductive health, prevention of violence against women, mental health and women's equity. She's also Chair of the Women's Mental Health Alliance, leading its initial establishment in 2019 and now with 35 members. Prior to joining Women's Health Victoria in 2015, Misha held senior policy roles within the Victorian Government, working across a range of portfolios, including public health, mental health, disability and child protection. I'm now going to hand you over to Misha and our amazing panel for the next half an hour. Thank you very much.
Thank you very much, Di, for that lovely introduction. And welcome to all of our panellists. I'd like to also acknowledge the traditional custodians of the land that I'm joining you from today, the Wurundjeri Willam people of the Kulin Nations, and pay my respects to their elders past and present. And thank you very much, Auntie Georgina, for the wonderful welcome you gave earlier. Before we begin, I'd also just like to let everyone know that we will be talking about some sensitive issues today that may be distressing for some people. And if the conversation raises any issues for you, and you need to take some time out from the discussion, please do that. Please also reach out for support if you need it, whether that be to a friend or family member or to a support service like one of those on the screen. I also want to acknowledge the strength and resilience of victim survivors of gendered violence and those with lived experience of mental illness and psychological distress, many of whom are fierce advocates for a better system to support women who've experienced violence and trauma. Finally, I want to recognise that the high level of gendered and sexual violence against women within mental health facilities continues to be a huge ongoing concern. We were really pleased to see the strong recommendation from the Royal Commission on this, recommending that all new mental health facilities be designed to enable gender separation and existing facilities be upgraded to enable this where possible. Of course, the devil will be in the implementation, and we'll be keeping a close eye on this. It won't be the focus of today's conversation, but if you're interested in learning more about this topic, I invite you to go to WHV's website, where you can watch the webinar that we hosted with Mental Health Victoria in August, which did discuss this issue in more detail, and Maggie was also involved in that discussion. So we've only got a short amount of time today, so I want to jump into the conversation, starting just with a couple of quick overview questions just to give a bit of context. So starting with you, Manjula, we know that violence against women and girls is one of the most common causes of poor mental health for women and girls, and women who've experienced violence are more likely to suffer from a range of mental health conditions. Can you tell us just a little bit about the mental health impact of gendered violence?
Thank you so much for having me here today. It's an absolute honor. The impact of domestic violence on the brain is one of trauma. And so our system, the brain system, reacts to it like anybody would in the situation of an emotional or a mental trauma. So the brain reacts like with fear, with fight or a flight in the case of a physical threat to life, or an emotional abuse. There's an ongoing stress situation. As a result of that, we are in a state of chronic stress and fear, which has long-term implications. So we know that domestic violence is associated with 7 times more post-traumatic stress disorder, 4 times more depressive illness, 3 times more panic attacks and anxiety disorder, 3 times more suicidal ideation. So domestic violence in women is the cause of biggest health burden. Even eating disorders, personality disorders, ability to cope with life, they are all affected by this trauma from which there is no escape for a lot of women. Thanks, Michelle.
Thank you, Manjula, and that's certainly some sobering statistics to start this conversation and to really frame the reason why we're having this conversation. Maggie, I wanted to ask you about your work with the Mental Health Complaints Commissioner. So the ABC recently reported that in the last financial year, the Commissioner received 36 complaints from victim survivors of family violence about their experiences in the public mental health system. Are you able to tell us just a little bit about some of those complaints?
Thanks for having me here today too. Without going into detail, some of those complaints were about the diagnosis that they received at the time, that consumers received at the time of when family violence was going on, and that they felt that they should have been diagnosed with post-traumatic stress disorder, but they weren't. So it was other diagnoses around that they weren't seriously enduring family violence at the time. Some of the other things were that they were unable to get female support, that their main contacts had been male clinicians and they weren't able to get female support. And some of the other ones were around information being shared with the perpetrator and actually being put back into the care of the perpetrator was another one of those issues.
Thanks very much, Maggie, for sharing that information, and certainly some really serious concerns there in terms of how the mental health system is responding to women who've experienced family violence, and exactly the reason why we're having this conversation today and why there's an urgent need to be changing the mental health system so that it is able to better respond to women who have experienced family violence. We've now had 2 Royal Commissions in Victoria. one into family violence, and more recently a Royal Commission into mental health. The Family Violence Royal Commission did make some really valuable recommendations around building the capacity of the health and mental health workforces to be able to better identify family violence, manage risk and make referrals. And some great work has happened through the rollout of the Multi-Agency Risk Assessment and Management Framework, or MARAM, and that applies to mental health services. On the other hand, while the Mental Health Royal Commission briefly acknowledged the impact of sexual assault and family violence on mental health and made some recommendations relating to building workforce capability in trauma-informed practice, it didn't really closely examine the links between gendered violence and mental health, nor did it highlight the gendered nature of trauma. But we know that that's a major gap for our mental health services, as some of those complaints have illustrated. So the focus of the rest of this conversation is really going to be about what needs to change to make sure mental health workers and our mental health system can better respond to victim survivors of gendered violence. Starting with you, Maggie, from your perspective, what are women who've experienced gendered violence looking for from the mental health service system when they need support?
I think they're looking for somebody who actually understands what they're going through. And so I will always champion lived experience, and certainly somebody who understands what they're going through, who understands the framework of family violence. I think it's too easy to just accept that clinicians will know how to answer and how to respond. It's certainly something that is in the front of my mind around what needs lacking in the system. And I certainly think the system is trying to work with it, but they're falling behind because there's so much and so much information and not a coordinated response.
Thanks very much, Maggie. And Kelsey, I know that you and your team have done quite a bit of research looking into some of the particular gaps in knowledge and skills among mental health workers and within the system in responding to women who've experienced gendered violence. Would you like to talk a little bit about that and where you see the opportunities for improvement?
Yeah, thanks very much. And I'm very excited to be here. I've had the pleasure of supervising some PhD students who've looked at this area. Carol O'Dwyer is one of them. But you know, throughout the board, whether you're in private or public, you're a psychiatrist or a psychologist or a counsellor of any sort, the dearth of training and ability to address current or recent domestic violence is a major need. Carol O'Dwyer did some beautiful work where I think it makes us think about what we need to do to address it. So she did some in-depth case studies and found that there were different groups of practitioners. So one group dismiss and deny gender-based violence. So they either think that if women talk about sexual violence in particular, it's a delusion, they dismiss it, or deny their experience completely. So some of that we've heard from Maggie. The second group acknowledge it, but are totally unprepared. So they're a group who are probably ready to, lap up some training, But the third group are the group who already understand it, have probably even been to some training, but the system's letting them down. So they're empathising and despairing. And we need different strategies for those different levels. If you think about it, the first is an attitudinal one. The second one is around, they really don't have the scripts and the procedures and know how to, as Maggie said, ask or respond. And the last group need the system to really step up. I was very sad to see the recommendations from the mental health, really not even spelling domestic and family violence and the gendered nature. But I think, but I think there's a special area within this around mental health coercion that Carol Warshaw talks about. And we've seen some examples in the press that it really wasn't on any of these practitioners' radars, that perpetrators are using mental health diagnoses and interfering, and as Maggie said, being really put into the care of perpetrators. I've certainly had patients where psychiatric reports have been court-ordered to go to the perpetrator, so who's an ex-partner. So that mental health coercion, where mental health is used with children, with families, with, where the person even convinces themselves, that just does not seem to be a language that mental health practitioners speak about.
Mm-hmm.
Would you like to add to that, Manjula?
Yeah, so one of the other factors is that doctors, psychiatrists actually understand domestic violence. They understand how to ask, they elicit it, but the bit that is missing is contextualizing it within the psychiatric diagnosis that they have, which means that they are, when a patient comes to a psychiatric or a mental health setting, they are often quite ill. They might be suffering from another mental disorder that may be quite separate to family violence. And and the family violence also has its own post-traumatic stress disorder, but they might, in addition, say, have a depressive illness, or they might have a psychotic illness. So the question is, how do you contextualize that family violence and post-traumatic stress disorder within your formulation of your understanding the whole of the patient, so that you are actually figuring out how much the family violence is precipitating the illness or perpetuating the illness. And so they are the two factors that are sometimes missing. So you can have the family violence diagnosis there and the patient here and their other illness, maybe delusional disorder, but they're not being married in together to create a proper, comprehensive biopsychosocial management of the patient.
Thanks, Manjula. And certainly the research that we've been doing certainly suggests that women, when they're seeking mental health support, are really looking for that sort of holistic approach that recognises the broader context in which they're living their lives. And of course, if they're experiencing family violence, then that must be a critical component of that. Otherwise, the system is putting them at greater risk. And that's certainly what we've seen from the recent ABC reports. Kelsey, I can see you want to jump in there.
Yeah, and I think some psychiatrists know how to ask, but many seem to be very reluctant to ask, in my experience. And the work we've been doing with psychologists, another PhD student, Sally Marsden, has been interviewing women about their experiences with counselling with psychologists, and that imposing of agendas and diagnoses onto women instead of, as Maggie says, really listening deeply to women's experience and their expertise by experience of what they know might help them, is a real mismatch, I think, in a lot of these interactions where the mental health practitioner is really bringing their own agendas into it, which sometimes domestic violence is in the formulation. I totally agree, Manjula, but sometimes it's not because they've never been taught it.
Yeah, go on. Sorry,
Maggie, would you like to jump in?
Yeah, because look, I think I can understand where psychiatrists are coming from, but I can't understand how they can make somebody not safe. I can't understand why safety wouldn't be a big feature of any decision that they were making. And the instances where consumers' lives have been put back into the hands of the perpetrator, and there is no way that the consumer would have been not speaking up or not saying something about that, but they're not listened to, and that's really frustrating.
Yeah, as Carol Warshaw, she's a psychiatrist in the US, says, the perpetrators look rational. And of course, because consumers, and survivors look traumatized, and we've had recent examples. I'm not saying I'm totally abhorrent of it, but I think that's how it gets led into it, is that perpetrators look healthier.
Mm-hmm.
Yeah.
Yeah, and so they're able to convince the interviewer that their view is the right one, because it's easy to collude with rational looking person.
Mm.
And I think it also highlights the lack of coordination between services as well. So we certainly saw in the recent ABC article that there were intervention orders against the perpetrator in that particular case. But we're not necessarily seeing conversations between family violence response services who may have been supporting the woman in that case, or perhaps working with the man, and mental health services. So one of the critical things also is in terms of that more coordinated and integrated service delivery, where women are experiencing family violence and also requiring support from the mental health service system. So I think that's also a huge opportunity for improvement within the system.
And we managed to do it with alcohol and drug and mental health. So it's just, moving that a bit further. Yeah.
Absolutely. Kelsey, would you like to speak to any of the sort of promising initiatives that you've seen perhaps in the general practice space that perhaps might be applicable to building capability within the mental health system?
Yeah, so we've just been funded nationally to, over the next 4 years, train primary care in this area. But more than training, because that's the problem. Training probably by itself does nothing, as we just heard, people who want to do it, but the system is against them. We need leadership, we need clinical champions in different areas to be able, for people who are practitioners, maybe even with their own experience, who actually can go to someone and say, I've got these cases, what can I do about that? The integration and coordination, so that it's clear where people can cross-refer to other areas. But it also needs a reflective practice and a reflective system where, people might think to themselves, oh, I mostly ask, but if you actually did an audit, they ask the ones that they think are okay to ask or something. Whereas every person with a mental health presentation, this area should be explored, every single person. And that's what we teach the GPs to do, because a currently depressed person, probably for a woman, evidence would be that up to half of them have probably got some domestic violence going on at home or in the recent past. So it's really that basic level, but with the supports around. Yeah.
Thanks, Kelsey. And I know that we often talk about a trauma-informed approach, but in practice, we're not necessarily really applying that approach. And as you're talking about, part of a trauma-informed approach is about, recognising that there may be a possibility that anyone who encounters the mental health system may have an experience of trauma, and that's even more likely to be the case if that person is a woman. I know, Manjula, you have some strong ideas around the lack of a gender-informed approach to response to trauma within the mental health system.
Yeah, so basically there is a little bit of money that is there for trauma centres in the Royal Commission into mental health systems. But that, as we know, trauma can arise from numerous sources, and each of them requires a different approach. For example, trauma from a war is different to trauma from a childhood sexual abuse, to the trauma from family violence. But, and so we need to have a specific dedicated trauma service for survivors of family violence, where there can be as Kelsey said, really genuine and trauma-informed care that is based on good attitudes and that is based on comprehensive knowledge. But as we all know, how the government systems work is that family violence is one silo and mental health is another silo. So when you talk about trauma center for family violence victims, it crosses those two departments and two ministries, and that has effectively stopped further conversation about that. Now, what we need is to develop a committee that will actually have people from all ministries, including experts in the area, so that we can and lived experience, so that we can actually create a Australia first trauma center in Victoria that will look after women who have who've been victims of family violence, and they have mental health issues, or they might even have physical health issues, and there might be collaboration with primary physicians and general practitioners and so on.
That sounds like a fantastic idea, Manjula, and potentially also a role or an opportunity for the collaborative centre that has been recommended by the Royal Commission to be part of as well. So ideally bringing a gender lens to research into mental health issues, including a gender-informed approach to trauma, and then looking at how we can translate that into practice and into the mental health system. I did want to also ask you, obviously you've talked about the different experiences of trauma that different people may have. I know you've worked quite closely with the Indian community and with women from diverse cultural backgrounds, and I wanted to ask whether you had anything to share in terms of particular considerations around working with women from different communities who may have experienced family or sexual violence.
Yes, definitely. So for women who are migrants into the country, they have a very different experience to people who've been born here, people who know the language, who know the systems, who know that you can ring the police if you're in trouble. So you're coming from a different country, you don't know the system, you may not trust the police, you don't know that there is, and they're often isolated. So they're the migration type issues, but built on that, then you also have issues like, you have to keep the family together, pressure to not divorce, pressure to not seek help, because that will bring dishonor to the family. And there's a stigma of the breakup of the family. There is a pressure to follow a norm of an ideal wife in the South Asian, and I would say mostly patriarchal cultures, is that the wife is submissive, they are always obedient, they're loving, they're kind, they look after the husband, they look after the children, and they bear everything with a smile on their face, which means that when there is emotional abuse going on, or even physical violence going on, that they are, well, I would say most likely use dissociation. They try not to acknowledge until it is too late. And so as a result, then we, for example, had a run of suicides recently. And previous to that, some years back, we had a run of domestic violence murders, and followed by suicide. So what happened was that the physical violence stopped, but a few years, because we advocated very, very strongly, and a few years later, then we saw a cluster of suicides. Now we are hoping that with our current advocacy that we will be able to bring that into focus. And once you bring it to a conscious focus, the community, kicks into action, and all the preventive and necessary steps get taken. But often that first step of breaking the silence is very, very hard for a lot of women. And also, there are certain practices that are specifically, like have a cultural cloak, and that is the dowry abuse, which is a form of a cultural economical abuse that happens in the context of a new marriage, where the groom in the South Asian context feels entitled to extort money from the bride and her family, and dissatisfaction with the amount of gifts can give rise to violence and emotional abuse and so on. And to that extent, we've been able to bring on a new law in Victoria, and it has become a national campaign, and we are hoping to get federal laws as well. And the other factor that happens in migrant communities is that a lot of the families are extended families. So the women don't just have one perpetrator, they could have multiple perpetrators. And so that can create difficulties. So, the migrant, the diverse experience is quite different for women who are born in the country. and we need to be aware of that.
Thank you, Manjula. Yes, certainly a whole range of complexities and different experiences that mental health practitioners will need to be aware of when working with women who've experienced family violence. We have had a very, very short discussion, and I know that we could have dived into this in much greater detail, and I hope to have the opportunity to do that with you and others. But just before we wrap up, really just wanted to ask each of you if you could make one recommendation to the Victorian Government regarding the implementation of the Mental Health Royal Commission reforms to improve outcomes for victim survivors of gendered violence. What would that be? Maybe we'll start with you, Kelsey.
Easy. Engage with victim survivors, engage with experts by experience groups. We're working with a group of women. Listen deeply to them because they know the answers.
Yeah.
And they're not genuinely engaging. So, you know, that's easy. And I know they don't have control. Fix family court psychologists, but anyway, we won't go there.
You can sneak in a second one. Manjula, how about you? If you had made one recommendation, what would it be?
2.
Okay, you can have 2 too.
Oh, sorry.
Definitely, the first one is family court reports, and the family court report writers. They are in. It's an absolute travesty of justice that is going on. And the last ABC report, you know, people read about that, and it was very much based on experience that, you know, that I've had. And the second one is, can we have a trauma center where the family violence and mental health can work together, please?
Great recommendations. Thanks, Manjula. And Maggie, would love to hear your recommendations.
Certainly about a trauma centre for family violence. That would be a good one. But the other one, and which is important for me, is that for someone to listen, and not just listen, but hear what victims are saying, what survivors are saying at the time that it's actually occurring. It's too late once something bad's happened. It's too late to go back.
Absolutely. Well, I can definitely hear some common themes coming out of those final recommendations from each of you. So look, thank you so much. I wish we'd had more time to discuss this in more detail, but I look forward to continuing this conversation with you into the future. Thank you so much, all 3 of you, for your contributions today. And I'll now hand back, I think, to Di to finish off proceedings. Thank you all very much.
Okay, thanks. Bye-bye.
Well, thank you very much to our panel. I'd really like to express my sincere thanks to each of our panellists, to Dr. Manjula O'Connor, to Maggie, Toko, Professor Kelsey, Hegarty, and to Misha Barr for a really engaging and insightful conversation on a very challenging but important topic. Thank you for sharing your observations, your experiences, and your expertise. More importantly, I think the panel have provided some clear ideas about the areas that need focus and the actions the Alliance can take in its future advocacy to make sure that women who have experienced violence and trauma are understood and can get the right support and treatment for their mental health. So thank you all once again.